Hello, my name is Tomi Malmström and I'm project coordinator from Aalto University, and I'm going to present a brief description of the project and the key findings. The name Managed Outcomes stands for Operations Management and Demand-Based Approaches to Healthcare Outcomes and Cost-Benefits Research. The project is co-financed by European Commission's 7th Framework Programme and started at the beginning of 2010. It has run for 3 years and ends in December 2012. Aalto University is the lead partner, with 9 other partners from across Europe forming the consortium. As most healthcare networks are regionally structured, the key aim of the project was to study the relationship between the organization of regional health service provider networks and health outcomes. Regional health service provider networks have not been studied from an operations management and demand-based approaches, and there is no existing methodology for such studies. That's why we have developed a new methodology which consists of case studies of selected patient groups and user surveys, which aim to identify patient-reported health states. Operational and economical modeling was used in the analysis phase, and additionally stakeholder workshops which supported the development of future scenarios. The case studies were carried out in health regions of 6 European countries, and the selected patient groups were type 2 diabetes, stroke, hip osteoarthritis, and dementia. These patient groups represent different operational aspects within healthcare. Type 2 diabetes is an example of chronic care organization where frequent access to care is typically required over many years. Stroke is a hyperacute process in which time to access of services can be of critical importance. Hip osteoarthritis is dominated by elective care where clinical decision leads to scheduled operations. Dementia care is particularly complex as it involves many stakeholders, including formal and informal care. Coordination across these service providers is crucial, and integration a key aspect of care. The key findings of the diabetes case were following. Division of the diabetes patients to demand-based segments helped to understand how services were organized. In the project, the patients were divided into demand segments, which were based on the severity of the illness. They all included clear differences in the services needed. A focus on early care and diagnosis was an efficient way to organize the care. This was the case especially in the Netherlands. The cost of care in early stages was low compared to the later stages. Further investment in care at the early stage should improve outcomes at relatively low costs. In addition, the patient-reported outcomes in the survey were better in the cases where access to primary healthcare was easy and frequent. The next patient group studied was stroke. The stroke case is all about rapid access to specialist care and rapid delivery of emergency care. Delays in patients seeking medical help could be reduced with better education about stroke symptoms so that relatives and friends know that they need to contact medical services quickly. Even though there is widespread consensus about best practice, progress towards the Helsingborg recommendations for stroke care is uneven, and there were some quite large differences in care processes between regions. For example, in some places all the patients were going through stroke unit, but in others patients were triaged between ward and stroke unit. In some regions services were well integrated, and in some the services were clearly operating as separate units. In the hip osteoarthritis case, the outcomes following operations were similar across the case regions, and overall hip replacement had substantial impact to health states of the patients. A high volume of operations in a hospital led to better clinical and process quality. Waiting time from clinical decision to operate to actual operation is a problem in many EU countries, but there were some examples where the waiting time had been successfully reduced. The improvements in process efficiency could result from political pressure or increased competition. The key processes that supported these improvements were faster patient throughput and sophisticated operating room scheduling, supported by advanced nursing skills. The regional costs of the hip osteoarthritis care were highly related to the amount of operations, and actually improved process efficiency had a minor role. The network for the dementia care was in all of the regions very complex and included a lot of different actors. To enable support for informal carers of the dementia patients, good integration is essential. Memory clinics were used in Finland to diagnose dementia, and more patients were identified there with mild dementia. Patients were admitted earlier to care homes in Finnish and German cases. In Greece, the care was more community-based, and people were mainly cared at home even with severe dementia. Other regions fell between these extremes. As a result of the greater availability of informal care, the total hours of care provided to people with dementia were much greater in Greece and Spain than in Germany and Finland.